Assalamu alaikum. Our lecture today about neurofibromatosis, tuberous sclerosis, and Sturge syndrome. Neurofibromatosis type 1, the most common neurocutaneous syndrome, is neurofibromatosis type 1 with an incidence of 1 in 3,000 to 4,000 births, as well as being one of the most common inherited central nervous system disorders. It is the most common autosomal dominant condition due to mutation on chromosome 17, which encodes for the tumor suppressor gene project neurofibromin, and the most common inherited tumor syndrome. Half of the children affected have new mutation. The diagnosis is made on the basis of at least 2 major criteria. Minor criteria are supportive of the diagnosis. Here we have a table for the diagnostic criteria of neurofibromatosis type 1, starting with the major criteria, including coffee OLED spots, freckling in the inguinal or axillary area, 1 plexiform neurofibroma or 2 neurofibroma of any type, visual pathway glioma, 2 or more leaf nodule of the iris, distinctive osseous lesion like sphenoid dysplasia or thinning of the cortex, first degree relative with the neurofibromatosis type 1. The minor criteria include small stature, macrocephaly, scoliosis, pectus excavatus, hamartomatous lesion of neurofibromatosis type 1, and neuropsychological abnormalities. Here we have multiple images showing the coffee OLED spots, neurofibroma, cortical bone defect, scoliosis, optic nerve glioma, and leaf nodules of the iris. Here we have another image demonstrate the coffee OLED spots, neurofibroma, leaf nodule of the iris, axillary freckling. Here we have multiple image X-ray showing the bone defect demonstrated by scoliosis, tibial bowing. As a result will be tibial fracture and fixation. CNS tumor in neurofibromatosis type 1 include visual pathway glioma, plexiform neurofibroma, cranial and peripheral nerve glioma. These may be diagnosed radiologically without recurrence to biopsy, and the diagnostic criteria allow the diagnosis of neurofibromatosis type 1 to be made purely on neuroimaging or as adjuvant to clinical finding. Visual optic pathway glioma are usually WHO grade 1 pilocytic astrocytoma and are the most common brain abnormality in neurofibromatosis type 1, occurring in about 15% of the patients. Most of these are diagnosed in childhood, but only half are symptomatic. Optic pathway glioma in neurofibromatosis type 1 are most likely to affect the optic nerve rather than the chiasm and postchiasmatic pathway, as opposed to non-neurofibromatosis type 1 optic nerve glioma, and are also associated with a better prognosis. Once the tumor involves the chiasm and hypothalamus, there is a risk of precocious puberty and greater risk of visual deterioration. Here we have an axial T2 weighted MRI showing diffuse high signal intensity of the left intraorbital optic nerve glioma. Here we have another coronal MRI weighted image showing the left intraorbital glioma. Fusiform expansion of the optic nerve and widening of the optic foramen may be detected on CT, along with a very characteristic sphenoid wing dysplasia and plexiform neurofibroma, which are a frequent association. Although CT can detect the intraorbital involvement of optic pathway glioma, this involves irradiating the eye and is less sensitive than MRI for delineating tumor within the chiasm and intracranial extension. Other orbital features seen in neurofibromatosis type 1 include dilatation of the optic nerve sheath due to a dural ectasia and intraorbital extension of plexiform neurofibroma, variable extension into the chiasm, lateral gingulate bodies, or optic radiation are best detected on MRI. It is important to identify the expanded nerve within the optic nerve sheath to distinguish it from neurofibromatosis type 1 associated dural ectasia, in which the optic nerve sheath is expanded by CSF rather than a tumor. Here we have multiple section MRI weighted imaging showing the dural ectasia of the right optic nerve as demonstrated here, associated with sphenoid wing dysplasia that demonstrated by enlargement of the right cerebral temporal lobe associated with giant plexiform neurofibromatosis. Here we have sagittal T2 weighted MRI showing the dural ectasia of the optic nerve sheath. Here we have T1 axial section, both contrast, showing no enhancement of this dural ectasia because it is just a CSF filling the space. Here we have the heterogeneous enhancement of the plexiform neurofibromatosis with a sphenoid wing dysplasia. In general, these optic pathway tumors are kept under observation unless symptomatic or progressive in less than 5% of the patient. Spontaneous involution is also well recognized. There is increased risk of other CNS tumor in neurofibromatosis type 1 with optic nerve glioma. They are usually WHO grade 1 pilocytic astrocytoma occurring in about 1 to 3% of the patients, particularly within the cerebellum and brainstem. Here we have multiple section axial MRI weighted image, T1 post contrast that show the left optic nerve glioma associated with another glioma in the brainstem, as we see here. Although other low-grade and higher-grade tumor also occur in the brainstem, they are usually less aggressive than non-neurofibromatosis type 1 brainstem astrocytoma and are more likely to be seen in the medulla and midbrain tectal plate glioma than the bones. Tectal plate tumor may cause aqueductal stenosis and teens hydrocephalus. These brainstem neurofibromatosis type 1 tumor are often biologically benign and may regress spontaneously, and therefore clinical management is generally not aggressive unless clinical radiological tumor progression is seen. Another characteristic lesion of neurofibromatosis type 1 is the so-called hamartomatous changes of neurofibromatosis type 1, also known as unidentified bright object neurofibromatosis bright object or area of myelin vacuolation. These are seen in about 60 to 80% of neurofibromatosis cases, depending on the age at which the child is imaged, and may have an impact on cognitive function. Here we have multi-section MRI showing the hamartomatous changes of neurofibromatosis. Here we have coronal MRI FLAIR image that's showing increased signal intensity in both globus pallidi. This is the hamartomatous changes of neurofibromatosis. Here we have axial T2 weighted MRI showing the increased signal intensity of both globus pallidi. Also here we have increased signal intensity, including the cerebral peduncle and left cerebrum hemisphere. Here another images, axial T2 weighted MRI showing the bright object of neurofibromatosis or hamartomatous changes of neurofibroma that's seen along the lentiform nuclei. These are said to be of high signal intensity on T2 and of low signal intensity on T1 in the area of brainstem and midbrain bones medulla, but they said that it will be of increased signal intensity in basal ganglia on T1 weighted MRI. These bright bodies have minimal mass effect and no contrast enhancement and occur in typical sites such as bones, cerebellar white matter, internal capsule, basal ganglia, thalami, and hippocampi. Their lack of growth, eventual regression, and lack of contrast enhancement can distinguish them from glioma. However, astrocytoma may develop in the area involved by an identified bright object of neurofibromatosis, and radiologically it can be difficult to distinguish them without serial imaging. Enhancement and increasing mass effect are suspicious for tumor development, in which case the involved area should be kept under regular imaging review. Plexiform neurofibroma are one of the main diagnostic criteria of neurofibromatosis type 1. These are multinodular lesions formed when the tumor involves neither multiple trunk or multiple vesicles of large nerve. Typical location is the orbit, where the tumor grows along the ophthalmic division of the trigeminal nerve. in association with sphenoid wing dysplasia. Here we have the giant plexiform neurofibroma involving the trigeminal nerve, the ophthalmic division of trigeminal nerve of the right orbit. Here we have another plexiform neurofibroma, but involve the lumbosacral lumbar plexus. These are hypodense on CT and generally do not enhance with contrast agent. On MRI, they have more heterogeneous appearance. They are of low signal intensity on T1 and of hyper signal intensity of T2 and variable contrast enhancement, although at least part of the tumor normally enhanced. Extension occur along the nerve pathway into pterygomaxillary fissure, orbital apex, superior orbital fissure, and cavernous sinus. Other characteristic sites include lumbosacral and brachial plexi. There is a malignant potential with a transformation to fibrosarcoma, weighted at about between 2% and 12%, although probably within a lower range. Neurofibroma are more homogeneous and well-defined lesions that cause diffuse expansion of the nerve. It may be possible to distinguish plexiform from other types of neurofibroma radiologically because the former are more diffuse lesions. One of the most common osseous lesions in neurofibromatosis type 1 is the sphenoid wing dysplasia that's marked by a bone defect, which allows the herniation of the temporal loop through the orbit. On a plain radiograph, this produces what's called MTR orbit sign. Clinically, there may be pulsatile exophthalmos due to transmission of CSF pulsation. The globe may also be affected with proptosis or enlargement. Here we have the sphenoid wing dysplasia as demonstrated here, absence of sphenoid wing with enlargement of the left temporal loop. This allows herniation of the temporal loop hemisphere into the orbit, producing what is called the bar orbit sign. This is another image of sphenoid wing dysplasia with a herniation of the temporal lobe into the orbit and producing what is called the bar orbit sign. Another osseous manifestation of neurofibromatosis is the kyphoscoliosis, which is due to primary skeletal dystosis. There may be also with skeletal dystosis, there may be a dural ectasia with vertebral scalloping and lateral meningeal contain CSF. Scoliosis may be seen in association with intrinsic spinal cord tumor or peripheral nerve neurofibroma. This is the skeletal manifestation of neurofibroma that's characterized by scoliosis, tibial bowing, recurrent fracture, and fixation. Other non-CNS neoplasia recognized in neurofibromatosis type 1 include pheochromocytoma, carcinoid, rhabdomyosarcoma, and childhood chronic myeloid leukemia. We will move on to tuberous sclerosis. Tuberous sclerosis is a multi-system genetic neurocutaneous syndrome that's characterized by hamartoma, cortical tuber, and benign neoplastic lesion, giant cell astrocytoma. The most frequently affected organs are the skin, brain, retina, lung, heart, skeleton, and kidneys. But the few manifestations that are associated with reduced life expectancy seen in this condition are in order of highest to lowest frequency, starting with a neurological disease, seizure, subependymal giant cell tumor, renal disease, angiomyolipoma, and renal cell carcinoma, pulmonary disease, lymphangioliomyomatosis, and bronchopneumonia, cardiovascular disease, rhabdomyosarcoma, and aneurysm. The classical clinical presentation of tuberous sclerosis is the tract of intellectual impairment, epilepsy, and adenomous ischemia, but there is a wide phenotypic range. There are numerous diagnostic, primary, secondary, and tertiary criteria for tuberous sclerosis, some of which are radiological and which categorize tuberous sclerosis as a definite, probable, or possible. Radiological primary. The primary criteria is the presence of calcified subependymal nodule, while non-calcified subependymal nodule and tuberous cardiac rhabdomyoma and renal angiomyolipoma considered as secondary criteria. Here we have multi-section axial and coronal MRI showing the subependymal nodule seen projecting into the lateral ventricle. Here we have a multi-section MRI. This is an axial T2 weighted MRI showing increased signal intensity subcortically in the left frontal area. And this area will be of low signal intensity on T1 and increased signal intensity of T2. This is what's called cortical tumor, which is considered as characteristic finding in patients with tuberous sclerosis. Here we have non-contrast enhanced CT scan showing the calcified subependymal nodule seen along the lateral ventricle, which is the primary criteria of tuberous sclerosis. Here we have an axial and corona FLAIR image showing the increased signal intensity, which is the cortical tuberous. In about 80% of patients with tuberous sclerosis, infantile spasm or myoclonic seizure are the presenting symptom. Conversely, 10% of the children with infantile spasm will have evidence of tuberous sclerosis. So structural MRI neuroimaging is indicated in these children. Ocular manifestation of tuberous sclerosis include retinal hamartoma seen near the optic disc in 15% of the patients and are often bilateral and multiple. On CT, they appear as nodular masses originating from the retina, and when classified, difficult to distinguish them from retinoblastoma unless these are so-called subependymal nodule. Also seen subretinal effusion may also be detected, microphthalmia, leukocoria, and other features. The intracranial manifestation includes subependymal hamartoma or nodule, subependymal giant cell astrocytoma, radially oriented linear point, and cortical tuberous. Subependymal nodules are the most common lesion and seen in about 88% to 95% of individuals with tuberous sclerosis. They may be calcified, and which is a useful diagnostic feature on CT and T2 weighted star or MRI. Calcification increases with age and is rarely detected under the age of 1 year. Histologically, they are indistinguishable from giant cell astrocytoma. Here, patients with tuberous sclerosis showing axial non-contrast MRI scan showing the calcified cortical subependymal nodule associated with giant cell astrocytoma. The giant cell astrocytoma determined by the location in the caudothalamic groove adjacent to foramen of Monroe, progressive growth on serial imaging, and presence of hydrocephalic contrast enhancement may be seen in both subependymal nodule and giant cell astrocytoma. The lack of myelination in infants help to identify white matter anomalies, which become less visible as myelination progresses. Subependymal nodule and linear parenchyma tuberous sclerosis lesion in infants younger than 3 months old are of increased signal intensity on T1 and of low signal intensity on T2, as opposed to the reverse pattern of signal intensity in older children and adults. We will move on to Sturge-Weber syndrome. Sturge-Weber syndrome is a congenital syndrome that's characterized by a port-wine nevus on the face and ipsilateral leptomeningeal angioma with a primarily parieto-occipital distribution. Bilateral involvement may occasionally occur. This is a port-1 nevus in an infant baby. The clinical manifestation include the onset of focal seizure appearing during the first year of life with developmental delay with progressive hemiparesis, heminopia, and intellectual impairment. The seizure progressively become refractory to medication. The leptomeningeal angioma cause abnormal venous drainage and chronic ischemia, leading ultimately to cortical atrophy and calcification. The later feature being usually very important by 2 years of age, skull radiograph may reveal the trim-line calcification within the cortices. In early imaging, the brain may look normal on CT as well as on MRI, even with IV contrast, because the bile angioma may not be conspicuous until the 2 years of life. Here we have what's called the trim-line calcification that's seen obvious on CT scan. The involved hemisphere progressively become atrophied, and bile angioma is seen as diffuse bile enhancement of variable thickness. Other findings including enlargement of the ipsilateral choroid plexus and dilatation of transparenchymal vein that communicate between superficial and deep cerebral venous system. Here we have multiple section MRI showing that atrophy of the right cerebral hemisphere, as we see here, with enlargement of the ipsilateral choroid plexus and enhancement of the bile angioma. Here we have the cortical vein, prominent superficial vein, and subependymal vein. Here we have multiple choroidal angioma that is associated with Sturge-Weber syndrome. Here we have axial non-contrast CT scan showing the atrophy of the hemisphere, of the right hemisphere, associated with the trimline classification of Sturge-Weber syndrome. The last topic is the neurofibromatosis type 2, as it's recognized from the most common to the rarest type. The rarest type of these 4 topics is the neurofibromatosis type 2. This is located on to an abnormality on chromosome 22 and occur about 1 in 50,000 pairs. Nearly all have bilateral vestibular schwannoma. Other tumors such as meningioma and other cranial and peripheral nerve schwannoma and ependymoma, including spinal tumor. While in adults, hearing loss is the presentation, seizure and facial nerve palsy are more common in children. Here, multiple section T1 post-contrast MRI showing the bilateral vestibular schwannoma in patients with neurofibromatosis type 2. Here we have axial T2 post-contrast MRI showing the meningioma with its dural tail and bilateral vestibular schwannoma with multiple spinal schwannoma. References and thank you.